I have several questions, and the first one is that we have many kinds of imaging modalities, such as IVUS and OCT, to evaluate coronary lesions. And what is your treatment strategies in selecting the imaging modalities to obtain optimal information?
Well, I think one of the problems is, as you mentioned, we have so many different ones. And we've relied so much on angiography for so long that we assume that we'll come up with one type of imaging modality that can do everything. That's just not going to happen. So you've got physiology to assess the severity of the lesion. I think that there's some anatomic information that can allow you to defer treatment of a lesion, but currently there's no anatomic information that can tell you that a lesion is hemodynamically significant or not. So if your question is hemodynamic significance in the cath lab, you have to do physiology or FFR. There are certain things that OCT is best for, better than anything else. I think that the assessment of stent failure should be done with OCT if OCT is available. That's just one example. If you've got a patient with multivessel disease and you're looking for a culprit lesion, OCT is a better technique in terms of assessing thrombus formation, plaque rupture, and so on. But there are some limitations to OCT in terms of stent sizing and implantation and optimization. IVUS has been around for almost 20 years. We know how to use it. We know how to use it to optimize a treatment. And that's probably what I would pick if my only concern was how well is a stent expanded and how do I size a stent and so on. So I think the issue is, what's the question? Once you understand what your question is, you can decide what imaging modality to use. And you can't expect that one imaging modality is going to do everything. That's the legacy of coronary angiography. So just like the rest of medicine, if you want to know whether somebody has poor left ventricular function, you don't do a chest x-ray. If you want to know if somebody has mitral stenosis, you don't do a nuclear study. So you have to ask the right question, and then you'll know what imaging modality to use.
So sometimes we have to use combination of FFR and IVUS, maybe FFR and OCT.
Unfortunately, problem is the cost. And the problem is teaching people how to use it, when to use it, how to interpret the images, how to do FFR correctly. You know, if you don't do the test correctly, you will not get the information that you need.
And please explain to the audience how to improve the usage and interpretation of the imaging modalities in the cath lab.
Well, there's no easy way. None of us are born knowing how to interpret these images. And sometimes what you think you see is not really what you see. So you have to learn how to interpret the images, just like you learn how to interpret a chest x-ray or a nuclear study or an echocardiogram. There's no substitute for spending time with somebody who knows what they're looking at. There's no substitute for doing cases. I would say my first recommendation is somebody spend a week or two in a busy cath lab that does a lot of imaging. A lot of imaging doesn't mean one case a day. A lot of imaging means one case an hour for a week or two. And then go home and do a lot of imaging and have a friend, a buddy, that you can ask for help if you try to understand them.
And would you tell us about the key messages from the PROSPECT trial?
Now, I have a very different take on PROSPECT compared to a lot of people. I think a lot of the messages from PROSPECT are clinical messages, not from the imaging data. For example, the event rate in PROSPECT was quite low. Death MI rate was 1% per year. Granted, these patients had their culprit lesion stented, were treated with statins and aspirin and clopidogrel and followed carefully as part of a clinical trial. But the answer is, if somebody comes with acute infarct and you stent the culprit lesion, you send them home on the right medication, and you follow them closely, they'll do pretty good. So that's one. At the other end of the spectrum, the question is, should we look for vulnerable plaques in these patients? And the answer is probably not really necessary. Again, because the event rate is so low, there are complications associated with 3-vessel imaging. We've learned from other studies that vulnerable plaques come and go. Some rupture silently and just heal. So I am fairly not optimistic about invasive imaging to go searching for vulnerable plaques. I think unless we can identify really high-risk patients where it makes sense, or we have some kind of non-invasive technique that tells us where to look, and then we look more carefully, I think that one of the messages of Prospect is that the search for vulnerable plaques in individual patients probably does not make a whole lot of sense.
And what would be your perspective of future imaging studies?
Oh, I think there's several. OCT has been around now for a few years, but there's almost no work that has been done on how to use OCT to guide stent implantation. So one thing I would do is a study to identify what are the OCT criteria for stent sizing and for stent optimization. That's one thing. I think that there probably could be a good randomized trial of IVUS versus angiography or OCT versus angiography, not just looking at single stents with in-stent restenosis as an endpoint, but the whole use of the technique, collecting all the information that we can about the procedure. I think that would be a second one. If people are interested in vulnerable plaque studies, I think we have to go beyond just identification of vulnerable plaque. First of all, we have to repeat Prospect using OCT or spectroscopy, and then decide to design a trial that would randomize patients to 2 different therapies. Maybe we randomize them to statins versus stenting of a vulnerable plaque. But it's clear that the studies that need to be done, either with new techniques such as OCT, have to focus on how to use it in the cath lab. And then beyond that, we need outcome studies.
Okay, thank you for your time.